Like to now introduce Dr. Anna Locke, Assistant Dean for Clinical Research, University of Michigan. She's a hepatologist at University of Michigan. I'm sure many on this webinar know her very well. She's been a former president of American Association for Study of Liver Disease, has led a therapeutic guideline development at the global level as well as in the United States. And we're very fortunate to hear her overview of current therapies for hepatitis B. Anna, thank you. You're on mute at the moment.
All right, can you see my slides?
Yes, please go ahead.
Okay. All right, thank you. So I'm going to talk about the current treatment. These are my financial disclosures. Well, we have a very effective treatment for hepatitis B, but we haven't had any new treatment in a long time. We have interferon approved many years ago, and the oral antivirals, the last one of which was 2008. Tenofovir alafenamide is not exactly a new drug, just a new formulation. However, the current drugs actually work pretty well in suppressing virus DNA replication. With 1 year of treatment, you can reduce HBV DNA by about 6 log, which is about 1 million-fold. And entecavir and tenofovir have very similar antiviral efficacy. Interferon does not suppress the virus to the same extent. However, it does have a higher chance of e antigen loss and S antigen loss. Now, one of the very interesting things is that when you suppress the virus, not only do you reduce inflammation, but you can actually also reverse fibrosis, even though we previously thought that fibrosis is irreversible. And this is very nicely demonstrated in the phase 3 tenofovir trial, where they had a lot of patients who had 3 liver biopsies at baseline year 1 and year 5. In red and pink are the patients with baseline cirrhosis. And you can see that at 1 year, this hasn't changed much, but by 5 years with prolonged virus suppression, there is reversal of fibrosis and cirrhosis. Moreover, we also know that antiviral therapy reduces the risk of decompensation. So these are untreated patients. These are patients with suppressed virus. You decrease liver decompensation as well as liver-related mortality. But when it comes to liver cancer, even just suppressing the virus DNA, you reduce that risk, but not completely reduce it unless the patients also achieve S antigen loss, which is a minority. And this is one of the reasons why recent studies are so focused on S antigen loss. Because with the current treatment, the oral antiviral, even with 10 years of treatment, you only get 2-3% of patients clear surface antigen. With interferon, it's a little higher, about 10%, but that's mostly in patients with genotype A. And that's not the genotypes common in Asian countries where the bulk of the hepatitis B patients are. So with current treatment, potent virus suppression can reduce hepatic inflammation and fibrosis, prevent progression to cirrhosis and liver failure, but not completely eliminate the risk of liver cancer. Nonetheless, the NUCs are very safe. Because the current treatment does not eradicate cccDNA or integrated DNA, and there's very low rate of S antigen loss, such that when you stop treatment, virological relapse happens in almost all patients, and therefore long duration of treatment is necessary. And as I've mentioned, the risk of liver cancer persists, even though it is lower instance. So there is, in contrast to hepatitis C, where we actually achieve a cure with 8 to 12 weeks of therapy. Here we're talking about years and sometimes lifelong treatment, suppression, but not a curative therapy. Therefore, guidelines do not recommend treatment for everyone, at least not at the time of presentation. Treatment is recommended for all patients with cirrhosis, regardless of ALT or DNA. But for those with no cirrhosis, treatment is recommended for those with active disease, which means that they have high DNA as well as elevated liver enzymes, or non-invasive or histological evidence of inflammation or fibrosis. Currently, we do not recommend treating patients with immune tolerant phase, which are the antigen positive, high DNA, but normal liver enzymes, unless they're older patients or they are pregnant, and there we're using it for prevention of mother-to-child transmission. We also are not recommending treatment for antigen-negative inactive patients with low DNA and normal liver enzymes. But there's a lot of controversy as to whether these two groups also deserve to be treated. So as I've mentioned, currently for patients without cirrhosis, treatment is recommended for those in the active phase. So higher DNA as well as elevated liver enzymes or histological evidence of disease. But then we all recognize that there are a lot of patients in the so-called indeterminate or gray zone. Many people misinterpret the guidelines and say the guidelines do not recommend treatment. Well, if you actually carefully read the guidelines, that's not true, because the guideline recommendation for patients with gray zone is if they have persistently elevated liver enzymes, and the DNA is elevated, and for antigen-negative patients, persistently elevated liver enzymes, you rule out other causes of liver disease, you should be considering treatment. Unfortunately, these are really in the notes and not in the bullet points, and therefore a lot of people did not recognize that. Now, in recent years, a lot of people pushing for why are we not treating these patients? They're young and they have high virus level, and we know that persistent presence of antigen and high DNA is associated with increased risk of cirrhosis, liver cancer, and liver-related mortality. And if we treat earlier, maybe we can prevent liver disease from progressing, less integration of HBV DNA, less cancer progression. And while the immune response is poor, it may actually be better when we treat patients when they're young. There are also studies that suggest that even in the immune-tolerant patients, they are at risk of cirrhosis and liver cancer. But in the meta-analysis, when we compare the immune-tolerant untreated patients with the treated non-cirrhotic antigen-positive patients in the active phase, the risk of liver cancer is not increased by not treating them, at least for a short period of time over a matter of years. I think that most of the strongest reason why we're not recommending treating the immune-tolerant patient is that the current treatment does not provide a lot of benefit. So this is a study of patients treated with tenofovir or tenofovir plus emtricitabine for 4 years, antigen positive, high DNA, normal ALT. Even after 4 years, not everyone have suppressed HBV DNA to undetectable, very minimal E seroconversion, no S antigen loss, and every single patient relapsed when treatment was stopped. So if the current treatment, unless you're willing to commit the patients to lifelong treatment, the benefit may be small. And we did a study in the Hepatitis B Research Network funded by the NIAID, including immune-tolerant patients, children, as well as adults. Here, the patients received entecavir lead-in, followed by combination of entecavir and PAC interferon. And we're hoping to achieve antigen loss and sustain viral DNA suppression, but that was only accomplished in 3% of children and none of the adults. So we were very disappointed. And therefore, my stance is that I would not be recommending treatment of patients in the immune-tolerant phase with currently available treatment. Now, that doesn't mean that if we have better treatment, we wouldn't be doing that. The reason for that is that majority of the time, DNA has already been integrated. These patients have minimal inflammation, fibrosis. They're at low risk of cirrhosis and liver cancer during up to 10 years of follow-up. More so, we find that some of the patients, even if untreated, do undergo spontaneous E seroconversion and might have durable remission. And with current treatment, we rarely ever help them with antigen seroconversion. The exceptions, the older patients, pregnant patients, and those who require immunosuppressive therapy, we would be putting them on antiviral. Well, the other group that people have debated whether we should extend treatment would be the patients who are antigen negative with low DNA, the inactive patients, or those in the gray zone. But the first thing is, how do we know if the patient is really in the inactive phase? Because of the fluctuations in virus DNA and liver enzymes. So the guidelines do recommend that you should really monitor patients for 3 times, at least 3 occasions over 12 months, and they're stable with low DNA and normal liver enzyme before you consider them to be truly inactive. Or you add a one-time quantitative S. Low quantitative S is much more likely to be associated with true inactive phase and not someone in the fluctuating phase. Well, why is it that monitoring patients make a difference? Because this is a nice study from Taiwan many years ago now. They follow antigen negative patients who start off with low liver enzymes. Now, of course, over time, some of them, the liver enzymes start going up, and these are the patients who are at higher risk of liver-related mortality. However, among those who have persistently normal liver enzymes up to 20-25 years, they really didn't have any liver-related mortality. So the true inactive carriers have pretty good prognosis. But you have to follow them to see if they truly stay in the inactive phase. And this is the tricky part because a lot of patients do fluctuate. And as I've mentioned, not only do they fluctuate, sometimes when you see them, you can't put them into any bucket. So we call these patients indeterminate phase or gray zone. Now, this is a study which follow a large number of untreated patients, and some of them remain in the indeterminate phase for many, many years. And they realized that, oh, if we don't treat these patients because they are in the indeterminate phase, they do have a higher risk of liver cancer compared to the patients who remain in the inactive phase for many, many years. But they also noticed that really the ones that develop cancer are the older patients. So the older patients, in fact, all the guidelines say when they're in the indeterminate phase and they are older, you should really be considering them for treatment. But there was also another problem with this study, because during the follow-up period of close to 12 years, they were not closely monitoring these patients. These patients had liver enzymes tested less than once a year and DNA tested roughly once every 3 years. So many of these patients might have moved to the more active phase, but were not identified and treatment was not given in a timely manner. Now, talk about recommendations for starting treatment, but what about stopping? Right now, guidelines would say if the patients have cirrhosis, leave them on treatment, don't rock the boat. But if they don't have cirrhosis and they were antigen positive at the beginning, we treat until yeast conversion and undetectable DNA and at least 1 year of consolidation therapy. With antigen negative patients, AASLD guidelines say we should continue treatment until S antigen loss. But the APOSTLE guidelines and EASL guidelines say, well, we can actually stop treatment in some of these patients because some retrospective studies suggest that taking patients off treatment after 3-4 years might be associated with a higher rate of S antigen loss. Now, initially, those were based on retrospective studies, but there are 3 prospective randomized controlled trials with patients who've been on NUC for several years, and they were randomized to either continue the NUC or to stop treatment. The 2 German studies show that stopping NUC resulted in a higher rate of S antigen loss compared to patients who continued treatment. The Toronto study did not show a difference. Now, the difference between the Toronto study and the German studies was that these were largely Asian patients. 97% of them were Asian patients. And we now recognize, and this is a very nice retrospective study that Harry Jensen put together, more than 1,500 patients, majority of them Asians. What they found is that these patients have been on NUC for 4 or 5 years. If they were Caucasian patients, and the quantitative S is less than 1,000, and you take them off treatment, they have a fairly high rate of S antigen loss. But for Asians, even if the quantitative S is less than 100, the rate of S antigen loss is only 33%. But there were very few patients whose quantitative S dropped to less than 100. Actually, overall in this study, only 5% of Asians achieved S antigen loss when you stop the NUC, but half of them had clinical relapse and had to resume treatment. So this is really not something that should be considered lightly. One has to really balance very carefully. As I've mentioned, with the ability to cure hepatitis C and Hep B being very complicated, many experts say, why do we make life so complicated? Why don't we just treat every surface antigen positive patients? Because after all, even patients who appear to have mild liver disease and low virus are still at risk of disease progression, and we need to constantly monitor them. But some patients don't come back, and we might miss the opportunity of putting them on treatment. But I would counter that. Well, even if you put everyone on treatment, you still need to monitor them, because if you don't monitor them, you wouldn't know that they continue treatment. And if they abruptly stop treatment, you might have a major flare. But also, antiviral treatment reduces the risk of liver cancer, but does not completely eliminate that risk. So for some patients, you might still need to do HCC surveillance. And if the patients don't take the treatment, they're not going to derive a benefit. And as I would show you later, spontaneous remission can occur with hepatitis B, and that's very different from hepatitis C. So this is what we did in the hepatitis B research network study. We started off with patients, majority of them didn't have cirrhosis, and they were not receiving treatment, and we monitored them very closely. These patients, median age of 41, only 1.5% had cirrhosis. Over time, as these patients developed multiple active disease, we started them on treatment. And if you monitor and treat as indicated, you can see that the risk of cirrhosis, liver cancer combined was extremely low. So if you're able to monitor patients, you can have good outcome, and you don't necessarily need to put everyone on treatment right away. Moreover, in this study, we did see patients with e antigen loss. 1/3 of the patients who were initially e antigen positive lost at e antigen. 70% of that was spontaneous, not due to treatment. We had 90 patients who lost S antigen, and almost all of them was spontaneous. So it's not true that everyone will invariably progress. A small proportion of these patients can spontaneously have immune control over the virus and can stay in remission. So my recommendation for hepatitis B is, it's a complex disease, and if we want to provide the best treatment, we as providers need to equip ourselves so that we can understand the disease, and we should participate in shared decision making. That means that we explain and we educate the patients. We present to them the options, and we help them arrive at a personalized decision that is medically appropriate and is embraced by the patient. But because hepatitis B goes through all these ups and downs, we have to constantly revisit the decision and monitor the patient. So a decision that I arrived at with the patient 5 years ago does not mean that that's the same correct decision 5 years later, because the patient is getting older. The virus level might have changed, and the liver disease might have changed. I hope that I've given you a good summary of where we stand now, setting the stage for all the new therapies. Thank you for your attention.
Thank you very much, Anna. That was an excellent overview and a lot of good perspectives just to focus on related to the current therapies. But I think and so we can cycle back to that during the panel discussion. It also just reveals the great demand for expanding treatment to benefit more patients, and that's where the opportunities for new therapies development comes in.